Good evening and welcome to the seventh presentation of our basic modules organized by the Federation of Clinical Pharmacists in India. I'm Ali Salim and I'll be moderating the session for today. So the rules are pretty simple and the same for all the sessions. Participants, you can post your comments below the video thumbnail in the website, and a feedback form will be made available at during towards the end of the session. So you have to fill the form to get your certificates, and it will be you can download it within 10 days. Then today's topic is antifungal spectra, and our speaker is Dr. Fatima Shemin. She's been working in antimicrobial stewardship at Amrita Hospital for the past 3 years, and she has a lot of experience in antimicrobial stewardship, and she's been associated with a lot of international and national projects. And before we start the session, I would like to inform you about our upcoming events. So first is our CP Conclave of 2023, which will be held in 15th and 16th November. And it is organized by Amrita College in collaboration with FCPI. Second is held in Pune, organized by the it is CP Summit 2023 in collaboration with FCPI. It is held in 25th and 26th November. Then we have ID Congress 2024, which will be held in ICRA Hospital, and it's also organized by Federation of Clinical Pharmacists in India. And the date will be in January 19th to 2021. So I would like to just confirm that this event needs a live in-person registration. So without any further ado, over to you, Fatima.
Good evening, one and all. Thanks for the kind introduction, Alia. So please grab a cup of tea or coffee and get comfortable. Welcome to our FCPI's online journey into the fascinating realm of fungi. So building on the knowledge from the previous session on the kingdom of fungi, the microbiology and clinical implications, today we will explore antifungal spectra. I do not have any relevant financial relationships with any commercial interests. Okay. So by the end of this session, you will be able to understand the basics of antifungals, the need for antifungal susceptibility testing, in vitro activity of antifungal agents against different fungal species, the use and coverage of each antifungal agent by assessing their spectrum of activity. And then we're also going to learn about some newer antifungal agents in the pipeline. So let's brush up over the basics. Fungal infections are also known as mycosis, basically an infection caused by any fungus that invades the tissues, resulting in superficial, subcutaneous, cutaneous, or systemic disease. Now, fungal infections or mycosis can be classified based on virulence as primary, which affect the immunocompetent host, opportunistic, which affect immunocompromised host. Now, based on site, this can be classified as local and systemic. There are many other classifications which was already covered in the previous session. Again, basics of antifungal agents or basics of antimycotics. I'm sure everyone knows this, the classification. Antifungal agents are classified according to their chemical structure. And there are three important classes that are clinically relevant, which include poly, azoles, and echinocandins. But let's go through everything. So first class we have here polines, which include amphotericin B and nystatin. Now we all know the first antibiotic to be discovered is penicillin. In case of antifungal, it is nystatin is the first antifungal agent to be discovered in 1950, which paved the way for the development of other antifungal agents. Next, we have echinocandins, which include caspofungin, micafungin, anitolafungin. Then we have another important class, the azoles, which include imidazoles and triazoles. But we'll focus on fluconazole, itraconazole, posaconazole, voriconazole. Then we have antimetabolite flucytosine, allyl amine terbinafine, and other antifungal topical agents. Next is the mechanism of action. Already it's in detail, it's explained in the previous session. So by the previous session, you have, the details of the fungal cell components, fungal cell, what it's made up of. So all that basics has already been covered, but we're just jumping into the mechanism of action. So first we have here the Pauline antifungal, that is the amphotericin B. They work by binding to ergosterol, which is a sterol found in the cell membrane of fungi. Now this binding creates spores, and eventually what happens? Cell contents leak out and finally cell death. Next, we have another important category, that is azoles. They inhibit lanosterol 14 alpha demethylase, which is involved in the conversion of lanosterol to ergosterol. Now, this will again damage the cell membrane. Next, we have griseofulvin and 5-fluorouracil. They act on the nucleus. They inhibit protein synthesis. Then we have echinocandins, which also inhibit cell wall synthesis. They also act on beta-1,3-D-glucan synthase, which is an enzyme that builds the fungal cell wall. Now, lastly, we have here the terbinafine, which inhibit the initial stages of ergosterol formation. So they act on squalene epoxidase and inhibit this conversion here. So that's all about the mechanism of action. Now we are moving on to the meat of our presentation, the important part, the spectrum of activity or the antifungal spectra. Spectrum of activity of antifungal agents means the range of fungi it can kill or inhibit. So we have broad spectrum, which include fluconazole, iconazole, fluotrimazole. Extended spectrum antifungal agents can also act on resistant strains. Narrow spectrum, which have limited coverage, example flucytosine. And under extended spectrum, we have posaconazole, voriconazole. So in this presentation, we are going to see all these drugs one by one. Now, what is the significance or importance of knowing the spectrum of activity? So first thing to understand how antifungal agents act on the diversity of different fungal species. It also guides in empiric therapy, where healthcare professionals can make informed decisions when they suspect fungal infections. It also helps in recognizing resistant patterns, also assist in selection of appropriate drug, and also help in providing better therapeutic outcomes. Now, the spectrum of activity of an antifungal agent is determined based on its natural spectrum of activity. Means some antifungal agents, they can be intrinsically or inherently resistant to, fungal species are inherently resistant to some antifungal agents, and some resistance are acquired. Now, based on model MICs of susceptible strains, based on pharmacokinetic data, and based on clinical outcomes and results. So based on many factors, the spectrum of activity of antifungal agent is determined. Now, this is just a point to remember here. When fungal species are included only when clinical efficacy is proven and relevant for approved indications. That means those fungal species are only included for in vitro testing, which is relevant for an approved indication, and species that induce local infection in sites where the drugs does not diffuse in sufficient concentration. Example, ketoconazole, they're active in vitro, but they are excluded from the spectrum of activity. Now, you will know about this you will understand this really well when I move on to discussing the in vitro activities of different antifungal agents. Antifungal susceptibility testing. So I'm just taking a hydration break here. Just have a sip of water or anything. We have a long way to go. Okay, so antifungal susceptibility testing. Now, identification and susceptibility testing are very, very important. They are very crucial in order to select an antifungal agent that will be effective for the patient. So, because of some reason is that some fungal species, they have varying ability to form biofilms in indwelling devices, catheters. It's like they form a barrier. so that antifungal agents cannot penetrate well. So we have to do an antifungal susceptibility testing. So this is just one of the reasons. Now let's discuss what is the rationale behind it. So first thing, to compare how well two or more antifungal agents work against a specific pathogen, to predict how well an antifungal agent will work in the body, whether it will cure an infection, to measure how quickly fungus become resistant to an antifungal agent, and to predict how well new antifungal agents will work against infections. Now, note a point here. If in vitro susceptibility does not ensure successful therapy. Similarly, if a fungal species is resistant in vitro, but that does not always predict that it is a clinical failure. So the effectiveness of antimicrobial treatment depends on more than susceptibility testing. There are various other factors in choosing a drug. The patient's immune status, the disease, the drug properties, the pharmacokinetic data, the organism's virulence, and all play a crucial role in determining treatment success. Now, for the indications of antifungal susceptibility testing, so in routine practice, for species level identification, to know what kind of fungal species is there. So for all candida isolates from deep sites like blood, normal sterile fluids, tissues, abscess, of all aspergillus genus level for all the molds, of non-candidal yeast isolates from deep sites. Then if selection of therapy is based on guideline and you're having a confusion whether the organism drug combination will work, you can go for an antifungal susceptibility testing. And it's also recommended for patients who have previous history of exposure to echinocandidates. Then, of course, in disease conditions where the patient is unresponsive to therapy in mucosal candidiasis, invasive disease with clinical failure on initial therapy, that is when the patient came with an infection, so we started an antifungal agent and it did not work well. So in such cases, we go for antifungal susceptibility testing. Then infection with species with higher rates of acquired resistance. If the patient is infected with unusual organism for which susceptibility patterns are not established or it's unpredictable, then for species levels of aspergillus and genus level for all mold infections. Now we are going to see different standardized methods. First, we have broth microdilution method. This is the most accurate method of antifungal susceptibility testing and gold standard for clinical laboratories. So it involves, in the picture you can see, so here you can see a 96 well plate broth. So in the broth microdilution method, smaller volumes in 96 well plates is being done where multiple tests can be conducted. So initially an inoculum suspension. So this suspension contains fungal species. This is added to these diluted antifungal concentrations, and then it is incubated at 24 hour at 35 degrees Celsius, and at the end MIC is measured. Now MIC is the minimum inhibitory concentration, which is the lowest concentration of antifungal agent that inhibit the fungal growth. The Clinical and Laboratory Standard Institute, I'm sure most of us know this, CLSI. So they have developed standardized broth microdilution method for yeast, filamentous fungi, the MIC clinical breakpoint values for systemically active antifungal agents, the interpretive breakpoints, all these values, we have the reference already from the CLSI. So based on this, we determine whether it is resistant or susceptible. Sorry. Yeah. Okay, I'm back. So Based on these values, we can determine whether it is susceptible, resistant, or intermediate. Next, we have the agar disk diffusion method, which is simple, cost-effective method for determining susceptibility of yeast to antifungal agents. So in this method, you can see in this picture, there is a disc which is impregnated with antifungal agent. This is placed onto the agar plate. The agar gel has the fungus, and this is then inoculated with the yeast sample. Then after incubation, you can see this is the zone of inhibition. So the zone of inhibition around the disc is measured and used to determine MIC. Zone diameter reference ranges have been also defined for several antifungal agents. Again, this is also there, and it's in CLSI standard, all the diameter reference ranges, clinical breakpoints are given. Okay, let's see some commercial MIC methods. Here we have E-test. E-test is a variation of disc diffusion method. It involves a strip of agar is impregnated with a gradient of antifungal agent. So the strip of agar has the antifungal agent. This is placed onto the agar plate that has been inoculated with the fungal sample, and the MIC is determined. This is also a little bit accurate method. It is useful for yeast, but its relevance for filamentous fungi is not yet established. So this is and all the the only disadvantage is that not all antifungal agents are available in E-test format. So it can be a time-consuming process too. So basically, the agar disc diffusion method is preferred for yeast, not for filamentous fungi, because as I said before, the relevance is not yet established. Next, we have sensititer yeast 1. This is a colorimetric microdilution test for determining the MIC of antifungal agent against yeast. Now, this is rapid, reliable method for antifungal susceptibility testing. And next we have is Vitek 2S yeast susceptibility. Now, Vitek 2 yeast susceptibility is a fully automated method for determining the MIC of antifungal agents against yeast. This is rapid, accurate, and reliable method. This is also used in clinical laboratories around the world. So here basically we get disposable cards where there is a gradient of antifungal agent. The yeast sample is then inoculated onto the card and incubated for 24 hours. And based on this, you get the MIC values. Okay, now we are moving on to charts. So this is the in vitro activity of antifungal agents against different fungal species. Now that is the important part of this presentation. So before moving on to that, I am just going to explain what you're going to see. So a blue box with double plus means strong activity. Green box with single plus means moderate activity. A yellow box with plus or minus indicate variable susceptibility, which means some strains, some fungal strains show susceptibility, some show no activity or completely resistant. Now, red box with 0 indicate no activity or resistant. On the right side, you can see a table. Now, these are the clinically relevant systemic antifungal agents. So from polines, we have amphotericin B. Then here we have the triazoles, fluconazole, itraconazole, posaconazole, voriconazole. Next, we have micafungin, caspofungin, anidulafungin, and then we have 5-fluorocytosine. Okay. Now, this is the in vitro spectrum of activity for systemic antifungal agents against yeast. So under yeast, we are going to see under yeast, we are going to discuss Candida species, Cryptococcus species, Pichia anomala, Trichosporum bigelli, or also pronounced as bigelli. So fungal nomenclature or fungal naming has been undergoing changes for more than a decade, but there are currently no guidelines for microbiological laboratories to implement these changes. So we are going to stick with old names. So first, let's talk about the Candida family. Approximately 90% of fungal infections are caused by Candida species, from superficial to systemic disseminated infections. 6 important pathogenic species are Candida albicans, Candida glabrata, Candida tropicalis, Candida parapsilosis, Candida auris, and Candida krusei. So we will discuss them one by one. So here I will highlight the organism, and on the right side you're going to see how it's going to look on chrome agar plate. So first we have the Candida albicans, most common Candida species. As you can see in this chart, they're usually susceptible to most of the antifungal agents here. They're known to cause candidiasis, oral thrush, vaginal yeast infections to invasive candidiasis. Next, we are having Candida auris. This is an emerging pathogen. It is famous for its intrinsic resistance to fluconazole. As you can see, they have no activity towards fluconazole and variable activity towards triazoles. And they have pretty strong activity towards echinocandins. They are known to cause serious infections, including bloodstream infections, wound infections. Next, we have Candida glabrata. This is usually resistant to fluconazole, but in this chart, you can see variable susceptibility towards triazole, strong activity towards amphotericin B and echinocandins. Now, the entire yeast family shows variable susceptibility towards 5-fluorocytosine. Okay, so Candida glabrata is also known to cause candidiasis, candiduria, invasive candidiasis, all serious infections. Next, we have Candida krusei. Candida krusei is intrinsically resistant to fluconazole. See, you can see here the red box, and pretty strong activity towards amphotericin B and echinocandins, and also moderate activity towards other triazoles. They can also develop secondary resistance to these agents based on recent literatures. Next, we have Candida parapsilosis. They are susceptible to most of the antifungal agents, as you can see here in the chart. They can develop resistance to azoles. They are known to cause candidiasis, catheter-related bloodstream infections, endocarditis. Next, we have Candida tropicalis. They're usually susceptible to all the antifungal agents, as you can see on the chart. And based on recent literatures, azole resistance is increasing, but they are known to cause candidiasis, pneumonia, meningitis, immunocompromised patients. These are the pathogenic Candida species. Now we can see rest of the Candida. Now we have Candida dubliniensis, closely related to Candida albicans. They're usually susceptible to most of the antifungal agents, and they're known to cause candidiasis, oral thrush in immunocompromised patients. Now this is how they look on chrome agar plate. Next, we have Candida guillermondi. Now this is a rarely isolated from clinical specimen, but they are usually susceptible to most of the antifungal agents, known to cause candidiasis, endocarditis, often affects immunocompromised patients. Next, we have Candida lusitani. This is considered as an emerging opportunistic pathogen, and it is resistant to amphotericin B, but the rest of the antifungal agents, it is active. Next, we are moving on to the Cryptococcus species. Now, Cryptococcus species cause cryptococcosis. This is a fungal infection. They are resistant to echinocandins in vitro, and they are susceptible to amphotericin B and other triazoles. Next, we have Pichia anomala. This is like an emerging opportunistic pathogen. The in vitro activity is similar to Candida glabrata, strong activity towards amphotericin B and echinocandins, variable susceptibility towards triazoles. They're also known to cause candidiasis and UTI. Next, we have Trichosporum bigali. Now, this is known to cause trichosporonosis, including severe pneumonia and meningitis. They are intrinsically resistant to echinocandins, and they have variable susceptibility towards amphotericin B and other triazoles, but you can see they have activity towards voriconazole. Now we are moving on to spectrum of activity for systemic antifungal agents against molds. I'm just having a hydration break. Okay. So under molds, we will be discussing the Aspergillus family, Mucorales, Fusarium, Dematiaceous molds, Pseudosporum apiospermum, Lomentospora prolificans. So first, let's see the Aspergillus family here. The Aspergillus species, it includes Aspergillus fumigatus, Aspergillus niger, Aspergillus terras, Aspergillus flavus. Now, these are the leading cause of human aspergillosis, aspergilloma, allergic bronchopulmonary aspergillosis, invasive aspergillosis, all aspergillosis infections. So they are susceptible to voriconazole, as you can see here in the chart, also susceptible to posaconazole and amphotericin B, except Aspergillus terras, which is resistant to amphotericin B. And all the Aspergillus are resistant, all the mold, actually the entire mold family is resistant to fluconazole. And they have variable activity towards echinocandins. Next, we have Mucorales, also known as black fungus. It was quite famous during COVID. I'm sure you might have heard mucormycosis, which is a serious and fatal infection. So mucorales are susceptible to amphotericin, as you can see here, and posaconazole. They are intrinsically resistant to voriconazole and echinocandins. Next, we have the Fusarium species. Fusarium species can cause a wide range of infections from superficial to disseminated. They are susceptible to amphotericin. Okay, they are like variable activity, but often susceptible to amphotericin B and voriconazole, but they are resistant to fluconazole and the entire echinocandins. They are known to infect severely immunocompromised patients. Next, we have Dematiaceous molds. They are known to cause a wide range of infections, including pheohyphomycosis, chromoblastomycosis. So, dematiaceous fungi are usually susceptible to amphotericin, posaconazole, itraconazole, voriconazole, but they have no activity towards fluconazole and other echinocandins. Next, we have Pseudosporium apiospermum. This is increasingly recognized as a cause of resistant infections, and posaconazole and voriconazole has some activity towards this species. Next, we have Lomentospora prolificans. This is resistant to most of the antifungal agents. As you can see here, full red boxes with a 0 means no activity, and higher MIC values for most of the antifungal agents. Higher the MIC, least effective. Okay, always remember this. So if a patient is infected with Lomentospora prolificans, how are you going to treat this infection? So we will get into it in a while. Okay, it's time for a break. Basically, it's a quiz time. So I have a question for you. Which of the following is considered the treatment of choice for mucormycosis in immunocompromised patients? So you have the options here: A, fluconazole; B, voriconazole; C, amphotericin B; D, caspofungin. So if you're watching me live, I think you can add your answers onto the comment box and we will get into the answer in a minute. I can give you a hint. So the answer is amphotericin B. So initially, amphotericin B is preferred. Now as step down, usually they prescribe also conazole too. Next, we are going to move on to spectrum of activity of systemic antifungal agents against dimorphic fungi. Now, dimorphic fungi is like they can exist in two forms. A mold form at room temperature and yeast form at body temperature. And here we have four fungal species. First is blastomyces. Now, they are known to cause blastomycosis, which is a systemic infection affecting the lungs, and they are susceptible towards amphotericin B, itraconazole, and they have a moderate activity towards posaconazole, voriconazole, variable susceptibility towards fluconazole, and the entire dimorphic fungi is resistant or show no activity towards echinocandids. Next, we have coccidioids, which is known to cause coccidioidomycosis. This is also a pulmonary infection. It can also spread and cause disseminated disease. They are also susceptible to amphotericin B, fluconazole, itraconazole, and other triazoles. Next, we have histoplasma. Histoplasma capsulatum. I'm sure most of you have heard of this. They cause histoplasmosis, which is a pulmonary infection, especially in HIV patients and immunocompromised patients. They are also susceptible to amphotericin B and other triazoles, variable susceptibility towards fluconazole. Next, we have sporothrix. Sporothrix is known to cause sporotrichosis. This is also susceptible to amphotericin B, itraconazole, and other triazoles. Okay, now we are going to see each antifungal agent, and I'm also going to show you a table where you will understand the values and how this is how we can know whether it is a good antifungal agent. So let's get started. First, we have amphotericin B. So they are sensitive to Candida species except Candida lusitani, higher MIC values. They are sensitive to Aspergillus species except Aspergillus terras. They have activity towards mucorales, but resistant towards demataceous fungi. They are sensitive towards dimorphic fungus, resistant to Pseudosporium species and Fusarium species. Now, this is the in vitro susceptibility of fungal species to amphotericin B based on broth microdilution method. So the first column, you have the fungal species. Second column, you have the number of isolates tested. Third column, you have the MIC range, and that is minimum inhibitory concentration. And the fourth column, you have MIC 50 and last MIC 90, which means it is the lowest concentration of antifungal agent, which is known to inhibit 50% of the organism or the isolates. And in MIC 90, 90% of the isolates. So you can see in this chart, first we have Candida albicans. And you can see the MIC at 50 and 90. It is 0.5, which means it has strong activity towards Candida albicans. Even when we see Aspergillus, you can see 0.51. But when we come to Fusarium and Pseudosporium apiospermum, you can see the MIC values here. It's huge, 832, which means this amphotericin B is not going to work for them. So amphotericin B is used for antifungal therapy for invasive serious mycosis. Consider it as a reserved antifungal agent because it's highly nephrotoxic. So this is reserved for very serious invasive infections and often second line if the patient is intolerant to other primary agents. But amphotericin B, here you can see in mucormycosis, it is the drug of choice. And there in the right side, you can see the other clinical indications where it's given as second line, especially in coccidioidomycosis, blastomycosis, invasive candidiasis, and rest of the infections. Next, we are moving on to fluconazole. Now, here you can see fluconazole is sensitive to Candida species, Cryptococcus species, but except Candida krusei, Candida auris, Candida glabrata. Dimorphic fungi, they are sensitive towards dimorphic fungi resistant to molds. So the fluconazole is not going to work for the molds. Molds means Aspergillus, mucorales, all that fungus. So you can see the in vitro susceptibility for Candida species. Candida albicans, the values you can see they are low, but coming to glabrata krusei, higher value. Means they're not going to work for it. Next, we have the indication. So fluconazole is chosen as initial alternative agent and often step-down therapy in fungal infections. It's given in candidemia for non-neutropenic, not critically ill patients who are not at a risk of fluconazole-resistant isolates. They're also given as prophylaxis for hematological malignancy patients who are not at a risk for fluconazole-resistant isolates, ICU patients, peritoneal dialysis-associated infections, solid organ transplant recipients. Now, other clinical indications include cryptococcal meningitis, onychomycosis, blastomycosis, tinea infections. Next, we have itraconazole. Itraconazole can cover yeast, Aspergillus, dimorphic fungus. They're resistant to mucorales, pseudosporium species, Lamentaspora prolificans. But when we compare fluconazole and itraconazole, it has wider spectrum of activity. And they are preferred for initial treatment of mild to moderate infections or step-down therapy in fungal infections like blastomycosis, histoplasmosis. They're also given as prophylaxis for invasive fungal infections as an alternative agent for Candida species. But when we come to drug of choice, itraconazole is the drug of choice for the treatment of lymphocutaneous cutaneous porotrichosis. Other clinical indications where it is used as an alternative drug is aspergillosis, blastomycosis, candidiasis, tinea infections. Next, we have posaconazole. This is also having wider spectrum of activity when we compare itraconazole and fluconazole. It can cover mucorales. Next, it is used as it's used in salvage therapy for invasive aspergillosis, candidiasis, coccidioidomycosis, and infections refractory to itraconazole or fluconazole. It's also given for invasive fungal infections and prophylaxis in neutropenic patients. So there are other clinical indications also for coccidioidomycosis, mucormycosis, etc. Next, we have voriconazole. Voriconazole has broader spectrum of activity against most of the fungal pathogens. As you can see, it can cover Aspergillus, Pseudosporium, Fusarium, Candida glabrata, krusei, but resistant to mucorales and Lamentaspora prolificans. But here you can see they can cover Fusarium and Pseudosporium species. They are used for treating fungal infections in patients greater than 2 years of age in invasive aspergillosis, esophageal candidiasis, candidemia, and disseminated candida infections, and treatment of serious fungal infections caused by Pseudosporium species and Fusarium species, only if the patient is intolerant or refractory to other therapy. Now, other clinical indications, as mentioned, candidiasis, fusariosis, neutropenic fever, and all these conditions, it can be given. Now we have a newer antifungal agent here. This is the newest clinically available advanced generation triazole antifungals. It is active against a variety of yeast, molds, and dimorphic fungi, as you can see here. This is the in vitro susceptibility values. But it doesn't cover Fusarium species. So isavuconazole has activity towards most of the Candida species. Its activity is similar to voriconazole and osaconazole. Can also cover Cryptococcus and Aspergillus species. Now, isavuconazole is used for treatment of invasive aspergillosis and mucormycosis in patients greater than 18 years of age. And it's an alternative agent for esophageal candidiasis, in fluconazole refractory disease, and mucormycosis. It's also given as prophylaxis against invasive fungal infections. Now we have echinocandins. Echinocandins are sensitive to Candida species, Aspergillus species. They are resistant to dimorphic fungi, mucorales, Pseudosporium species, and Fusarium species. Now, echinocandins, they are usually given for treating invasive aspergillosis, candidemia, candidiasis. They are used in empiric antifungal therapy in neutropenic fever, and for patients who are refractory to or intolerant to other therapies. So it's a drug of choice in Candida auris infection, and it can be also given in severe cases of candidemia, esophageal candidiasis, prophylaxis of Candida infections, in stem cell transplant patients, and also in invasive aspergillosis. Okay, so I have another question for you. Which of the drug will you choose to treat Candida auris infection in a neutropenic patient? A, you have amphotericin B. Then you have caspofungin, fluconazole, and 5-flucytosine. There is a hint for you. So we just discussed this in a while. So it is, of course, caspofungin. I just explained this before itself. So next we are moving on to 5-fluorocytosine. This is a narrow spectrum, usually given in combination with amphotericin B. It is sensitive towards Candida, Cryptococcus, Aspergillus species, resistant to dimorphic fungi, mucorales, and Pseudosporium species, and Fusarium species. You can see a limited coverage, and it's used for treating systemic fungal infections, example, bloodstream infections, endocarditis, UTI, meningitis, pulmonary infections caused by susceptible strains of Candida, Cryptococcus in combination with other antifungal agents. And then you can, they are indicated, for example, in cryptococcal meningoencephalitis. The preferred regimen for a non-pregnant adult is that you give amphotericin B with flucytosine. So you cannot give it alone. Now we are moving on to newer antifungal agents. Rezafungin, this belongs to echinocandin class. They are similar to other echinocandins. Their FDA designation is QIDP or fast track. QIDP means antifungal agents or antimicrobial agents which are intended to treat life-threatening infections. And this is approved for candidemia and invasive candidiasis, prophylaxis of invasive fungal infections in stem cell transplants. And next we have ibrexafungerp, which is a terpenoid antifungal agent. It inhibits glucan synthase, an enzyme involved in the formation of an fungal cell wall component, that is 1,3-beta-D-glucan. I hope you remember there is an antifungal class which inhibit 1,3-beta-D-glucan synthase, that is echinocandins. So they inhibit glucan synthase, that enzyme itself. So It can cover multi-drug resistant Candida species, Aspergillus species, and it's also under QIDP designation. It is approved for treating vulvovaginal candidiasis, invasive fungal infections, refractive, refractory to standard therapy. Next, we have olorofim. This is the first member of the class orotomide class of antifungal agents. They can cover Aspergillus species, Lomendospora species, Cerosporin species, and other endemic fungi. The mechanism of action is that it inhibits dihydroorotate dehydrogenase, which is an enzyme involved in the biosynthesis of pyrimidine. So pyrimidine, and this can also affect cell wall and cell cycle regulation. So this is the mechanism. And in vitro testing of different clinical isolates from different regions have showed minimum inhibitory concentrations for all these species. And it is approved, it's an orphan drug, means it's not available for the public. It's it's given for people who have this resistant infection, and those are refractory of resistant invasive fungal infections. Next, we have fosmanogepix. This is GWT1 inhibitor. Now, GWT1 is an enzyme of the fungus. It inhibits a step in the fungal cell wall protein synthesis, leading to the disruption of cell wall integrity. It's currently undergoing evaluation in multi-center phase 2 clinical trial for treating invasive fungal infections in neutropenic patients and to Aspergillus or mold infections. Next, we have oteseconazole. Oteseconazole belongs to the category tetrazole. It's an azole antifungal agent. They have broad activity against echinocandin-resistant Candida glabrata and other dimorphic fungi. They are approved for treating acute recurrent vulvovaginal candidiasis, moderate to severe onychomycosis. Okay, we are moving on to the last slide. In vitro activity of these newer antifungal agents. First, we have resafungin, you can see. So I'll explain the box first. So the first column is the newer antifungal agent. Next is Candida species, which include wild type and echinocandin resistant. Then we have Aspergillus species, which include wild type azole resistant. Then we have Mucorales, Fusarium species, Cerosporin species, and Lomentospora species. Now, green means they're active against most isolates. Yellow means variable activity. Orange means marginal activity. Either high MIC or few isolates are susceptible. Red means no activity. And white, no data available. So resafungin has activity against wild type Candida species, except Candida parapsilosis. It has higher MIC values. It cannot act on echinocandin resistant Candida species, but it have good coverage for Aspergillus and no activity towards Mucorales, Fusarium, marginal activity towards Cerosporium and Lomentosporum species. Iprexa fungum, you can see they are having pretty good activity against Candida and Aspergillus species, but resistant to Mucorales and Fusarium species, and variable activity towards Cerosporium, Lomentosporum species. Coming to olorifim, they have no activity towards Candida species, but they're active towards Aspergillus species and Cerosporium and Lomentosporum species, and variable activity towards Fusarium species. Next, we have fosmanogepix. It has activity against Candida species, except Candida krusei. They have higher MIC values. It's active towards Aspergillus species and Fusarium species, Cerosporium species, and Lomentospora species, except few isolates. When we come to oteseconazole, they have good activity against Candida species. There is no data available for Aspergillus species, active towards Mucorales, and marginal activity towards Fusarium species. no activity towards Cerosporum lumentosporum species. Now, the key points is that the range of fungal species against which the antifungal is effective is referred to as spectrum of activity. Antifungal susceptibility testing is necessary to identify fungal species from fluid samples, especially in invasive disease conditions, species with high acquired resistance and unusual fungal pathogens. And if a specific fungus has a lower MIC value for most of the antifungal agent, treatment choice will be determined by practical clinical guidelines based on the patient factor. So that's all. I hope this was informative for everyone watching this. Over to you, Alia.
Hi. I don't know how you managed it. I can see how sick you are. Really appreciate you for that. So we have some questions.
Thank you, Alia. Yeah.
Can I go ahead with the questions?
Yeah, sure.
Yeah, first one is what is salvage therapy? Can you explain more about it?
Okay. So basically, salvage therapy means an alternate therapy. Like if a patient is having a fungal infection, and initially he will be treated with a drug, and if that drug does not work for him, the primary agent doesn't work for him, we go for alternative agents. So you can refer that as salvage therapy. Or even if the patient is intolerant also, that name is given as like alternative therapy.
Thank you. Second one is what are the benefits of QIDP?
QIDP is a kind of designation assigned by FDA. It's like Qualified Infectious Disease Product Scheme. So this is to promote the development of drugs to treat serious and life-threatening infections, especially infections where there are multi-drug resistant strains involved. And when there is no other, whatever drugs are available, antifungal agents, when that doesn't work, we can go for these drugs which have this designation. And it's like limited, it's a limited option. That's
Okay.
it.
I think one more is there. Can you explain about orphan drug?
Okay, now orphan drug is also not available for public use. That's also in limited quantity where it is given for treating an infection, and it's usually that term is given for treating rare medical infections. So basically fungal infections where you see multi-drug resistant species, and it affects it affects in limited people, low community level. You are not going to get that drug as such. Maybe one or two patients are affected with such condition, you give this drug as orphan drug.
I think that's it. Thank you so much.
Thank you.
I don't know how you held it together in this state of health. I
Yeah,
really appreciate it. So before we
thank you.
conclude, I want to just go through the conferences again. We have our CP Conclave in November. Then we have a CP Summit in Pune, which is organized by the IPA Student Summit. And then we have the 2024 ID Congress, which will be held in ICRA Hospital. So I would like to tell you all to stay focused and stay tuned and follow our social media pages so that you can get more updates.